Good morning and welcome to the Common Part B Diagnostic Radiology Rejections and Denials webinar. My name is Mary Moko. I am a member of the WPS Provider Outreach and Education team, and I'll be your presenter today. I am joined by my teammate, Tom Ryan, who will be assisting with some behind-the-scenes help. This webinar is for those people who are wishing to learn about the most common reasons for diagnostic radiology rejections and denials on Part B claims submitted to WPS. CMS does require the MACs, the Medicare Administrative Contractors, to include this education in order to prevent future claim rejections and denials. Now, just as advertised, the information that I'm presenting today in this webinar is based on actual claims data. The presentation is available to download from our live events webpage, and Tom has placed the address or the link to that page into our chat. You may take time now to download the presentation materials if you haven't already done so. We are recording this session, and barring technical difficulties, we will post this recording on our Encore Presentations webpage, where it will remain for about 60 to 90 days. The recording will also post on our YouTube channel, where it will remain as long as the information remains current or until we otherwise decide to remove it from our YouTube channel. Now, if you have questions, please place them into the chat. I will answer questions as time permits, but if I don't get to your question, I will email you the response to your question following today's webinar. Now, if you have a specific question on a specific claim that is in processing, already denied, or otherwise sent to Medicare, I can't answer those claim-specific questions because I don't have access to that claims history, but you can get help by calling our customer service department. Someone will be happy to help you and access that claim edit trail in the system. We include this disclaimer in all our live events, and we do so to let you know that this presentation is really for educational purposes only. I did make every effort to verify that the information I'm providing today is current and accurate, but it is indeed subject to change. It is on the CMS website that you will find the Medicare rules that determine final coverage. These laws, regulations, and rulings will always prevail. CMS prohibits recording this webinar for profit-making purposes, so we ask that you refrain from taking any screenshots or recording this presentation. We will create an encore of this presentation, and you can use that for any future reference. Here is the agenda for today's webinar, and this is exactly what the advertisement stated. This is specifically what I plan to talk about today. Our goal is to share with you the most common rejections and denials for diagnostic radiology claim submissions sent to WPS. I'm going to define rejections and denials, reveal the reasons for rejections and denials based on the data that I pulled and analyzed. I'm also going to discuss ways to fix and avoid these, and I'll be providing many resources along the way. This is a lot of information to share in 60 minutes. I'm going to be moving quickly through the slide deck, and I may ask you to review some of the information following this live presentation. That information is mostly a list of helpful resources. There is just many of them I've included so that following today's live presentation, you'll be able to go back to those great resources that we're referring to during this presentation. Based on the American Medical Association's copyright notice for CPT codes, descriptions, and other data, I've included this CPT copyright notice in my presentation materials. Your continued participation today during this presentation infers that you agree to the terms of this copyright notice. Now, in order for me to discuss rejections and denials, I need to provide a bit of information about the claims process itself. Now, based on a law that requires that most providers submit claims electronically, when submitting claims, reports generate to confirm claim receipt and also report more specific information. Now, one of these reports is called the 276-277 report. Our electronic data interchange, or EDI staff, has created the Medicare 276-277 companion guide. And what this does is help submitters understand the claim requirements and know when they need to correct and resubmit the claims. Claims that move past those pre-pass edits will generate a remittance advice. Sometimes people call this the notice. Some people call it the remit or the RA. There are two formats of the remittance notice: the electronic remittance advice, or the ERA, and also the standard paper remittance, or what we call the SPR. Now, with very few exceptions, most providers are going to receive that electronic remit notice. The RA provides information to the provider. For adjudicated claims, those that are actually processed, you can find information about a lot of things, such as adjustments, denials, missing items, even refunds, and sometimes even offsets. On the remittance advice, you will find various reason or remark codes. These are typically in an alphanumeric format. When claims pay differently than billed, a claim adjustment reason code appears on that remittance advice. Now, sometimes a remittance advice remark code will also appear. These expand on details described by the reason code to provide more details about an adjustment. There are also another type of codes on the remittance advice called group codes. These assign financial liability for any unpaid claim balance. A CO group code stands for contractual obligation. This means the provider is liable and can't bill their patient. A PR group code means the patient is financially responsible. We hear a lot of comments about these codes. Providers often speak with someone in customer service and state that they believe these codes are too cryptic. Sometimes we hear that these reason codes that print out may contain an outdated acronym. Now, while we'd really like to help, it is another contractor, not WPS, that maintains these codes for CMS. You can find a link to the code lists on the Washington Publishing Company's website. It is on the Washington Publishing Company's website where you can find contact information should you wish to suggest a change to one of the reason or remark codes or those code explanations that I talked about. This slide shows a side-by-side comparison of rejections versus denials, and it's really important for you to understand that they really are very different things. Sometimes I think that we use these words, rejection and denial, interchangeably, but we really shouldn't be doing that because they're really two very different things and call for different actions. A rejection or a rejected claim is unprocessable. We can't process it. It's returned on what we call the front end before that adjudication occurs. The reason for a rejection is that something is missing or invalid, incorrect. It just doesn't make sense. Because they're never really processed, these these claims have no appeal rights. What you need to do is resubmit the service to Medicare. Now, on those remittance advice that are sent out when a claim is rejected, you will see those reason and remark codes that I talked about earlier, specifically an MA130. And there's a typo here. It should read CO16, not CO15, as shown in your presentation materials. Those are the codes that you're going to see on the remittance advice for a rejected claim. A CO16 means that the patient is not liable. Remember, you need to fix it and resubmit the service to Medicare. Send a new claim to Medicare. A denial, on the other hand, is a claim that is actually adjudicated. The remittance notice is going to send notice of the denial. That is why it failed to meet Medicare's payment criteria. Now, it could be due to a law or what we call a statutory requirement. Perhaps the claim did not meet Medicare's medical necessity criteria. This would include any utilization or frequency parameters. And claims sometimes also deny due to eligibility. It could be eligibility for the provider, or it could be eligibility for the patient or the beneficiary. On a remittance advice, in most cases, with few exceptions, and I'll talk about one of the exceptions later, you will see the MA01 code, and what this does is provide the appeal right to the provider. The patient liability, of course, for denied services is determined. Now, during the next slides, I'm going to discuss whether you need to correct or appeal the claim. After reviewing your remittance advice, you're going to need to choose your action. For an unprocessable or rejected claim, you're going to need to fix the error and resubmit the claim to Medicare. Send a new claim. If the claim or claim line denied, there may be multiple actions to choose from. You may be able to simply resubmit the service. You might be able to use the clerical error reopening or CER process to fix a clerical error. And CMS defines clerical errors as human or mechanical errors on the part of the party or the contractor. Another action to consider then is an appeal. Again, the remittance advice, with few exceptions, will provide appeal rights. Registered users can use our SecureNet Access Portal, or SNAP, to render or request a clerical error reopening, or to request an appeal. Now, this is just one of those self-service tools that are really the most cost-effective and efficient means to get the job done. Our portal user manual provides illustrations and also step-by-step instructions on how to use these and other portal features. For claim denials, most often you can request an appeal, and of course your remittance advice is going to include that right to an appeal if there is indeed a right to an appeal. The purpose of the appeals process is to ensure the correct adjudication of claims. Now, physicians and suppliers and beneficiaries all have the right to appeal claim determinations made by MACs, but it differs a little bit. The beneficiary or their representative may request an appeal on any service that's processed for them. Providers and suppliers may appeal services for which they accepted assignment. Now, for unassigned claims, though, providers and suppliers can act as the beneficiary's representative, but the beneficiary would need to sign an authorization statement. In addition, providers and suppliers may request a redetermination on an unassigned claim if Medicare denied the service as not reasonable and necessary, or if the provider or the supplier billed in excess of the limiting charge. And of course, if that was the case, whenever a provider bills in excess of the limiting charge, they would need to refund any amounts collected from the beneficiary. Now, there are 5 levels of appeal. The first level of appeal is the redetermination, and it is the only level of appeal that is rendered by the Medicare Administrative Contractor. So WPS, being a MAC, renders only the level 1 appeal called a redetermination. Timeframes apply to each of the 5 levels when submitting an appeal. And additionally, there's a minimum amount in controversy that applies for levels 3 and 5. And I'm going to talk about those 5 levels in just a minute. You can combine like denials on more than one claim in order to reach that amount in controversy for level 3 and level 5. On our website, we have a resource called How to Appeal a Claim Determination. It includes a lot of information, including who can submit an appeal for an assigned claim versus a non-assigned claim. But one of my favorite appeals resources is the one that I'm sharing on this slide. It is the CMS Fee-for-Service Appeals Process Flowchart. This is updated annually, so you'll want to make sure that you look to the bottom of this flowchart to see if it's current. Of course, at the beginning of a new year, you'll want to make certain that CMS has already updated this flowchart, which has been out there for years, but again, updated annually. This shows after the initial determination for the standard process appeal for Parts A and B, and for the expedited process that applies for some Part A only, that after the initial determination, there is those 5 levels of appeal. This flow chart shows it really nicely at a glance. That's why I really like this CMS product. The first level of appeal is done by the MAC. It's called the redetermination. Second level is the qualified independent contractor reconsideration, followed by the Office of Medicare Hearings and Appeals. We sometimes call this the administrative law judge hearing. The fourth level of appeal is the Medicare Appeals Council, and then finally, the fifth and last level of appeal is in federal district court. Now, I told you just a little bit ago that there's time frames that apply. You can see the time frames here on this flow chart. Not only do you see the time frame for submitting a level of appeal, but also the time frame that the contractor has to render that appeal determination or decision and send notification. This also shows you those amounts in controversy, or AIC. For third level, you can see it's greater than or equal to $190. And for the fifth judicial review level in federal district court, the amount in controversy is greater than or equal to $1,900. And those amounts in controversy, can also change from year to year. Now, the next portion of today's webinar really focuses on the data. Just as I advertised, I used a tool that we call the Claims Data Dashboard to pull the data that I plan to share with you today. Now, this data dashboard is an interactive tool. It was designed by our data analysts in our Insight department. Insight is the name of the unit at WPS that's responsible for mining our data, identifying trends based on that data, and among other tasks and responsibilities that they have. They created this tool so people like Tom and I can go out and fill in the filters for the data we want to see and view it. And this slide here talks about ways we can view that data. There's many different ways that we can view it. We can, in an instant, folks, and I mean just with the touch of a button, view rejections. We can choose to view denials. We can drill down by state and even county. We can also view rejections and denials by reasons, by codes, or even choose specialties to drill down that data we're looking at. And for today's presentation, we're looking at diagnostic radiology or specialty 30 claims. We can also use this dashboard to view trending. Trending alerts us to those spikes or increases that require education. Now, the data that I'm sharing today is all specialty 30 submitted claims for jurisdiction 5 and jurisdiction 8. So that means the states of Iowa, Kansas, Missouri, Nebraska, Indiana, and Michigan collectively. Now, as I mentioned, the dashboard does allow us to drill down by a specific state or states and even counties. I pulled data for our entire jurisdiction. For those of you that may be wondering what a specialty code is, I talked about specialty 30 a couple of times now. It's a code that's assigned to WPS providers when they enroll or during the enrollment process. No, during enrollment, most providers can self-designate their specialty, and while a provider can designate their primary specialty, they can also designate a secondary specialty and even a third specialty. But it's important to recognize that the specialty used during initial claim processing is that primary specialty, the one designated, self-designated during the enrollment process. Now, there are some situations where a provider will request an appeal. They'll stipulate or tell us their secondary specialty in order for Medicare to make payment. Now, again, specialty 30 is diagnostic radiology. I pulled claim submission dates November 1 of 2024 through January 31 of 2025. And that data dashboard from which I pulled the data for this webinar, the information I'm going to share with you, was last refreshed on February 10 of 2025. So here then, just as promised in the description of this webinar, I am revealing to you the most common rejection reasons for specialty 30 claims submitted to WPS. The numbers that you see here on this slide represent the number of claim lines. So this is rejection reasons and the number of claim lines. These are the top or the most common rejections for your specialty. This claim has been forwarded to Palmetto RRB. RRB stands Railroad Retirement Board, and this means that 1,608 claims were rejected by WPS during that 3-month window of time for specialty 30 claims, because the claim shouldn't have come to WPS to begin with. It should have went to the Railroad Retirement Board claim processor, which is Palmetto. Second most common rejection reason is that the rendering physician number is invalid and missing. If you think back to that comparison slide I talked about, claims are rejected because something is missing, incomplete, invalid, doesn't make sense. Over 1,100 claims rejected. The clinic number is missing or was not entered is also one of those most common rejection reasons for diagnostic radiology claims. Over 1,000 claims. Facility or lab name and address or PIN missing from claims was over 1,000, not well over 1,000, just over 1,000. And the last one there is that the claim should be sent to United Mine Workers of America for processing. And United Mine Workers of America is the entity, the health plan that processes Medicare claims for retired coal workers. So over 500 claims for diagnostic radiology services rejected. Remember, for rejected claims, you need to fix it, resubmit it. I thought it would be interesting not only just to share those common reasons, but maybe take a look at the codes that are being rejected and denied by WPS. Right now we're talking about rejections. The most commonly rejected code, CPT code, for your specialty or this specialty is 71045, and that is your single view chest x-ray. Over 1,300 rejections. And right there on this slide, you can see the reasons why we are rejecting that CPT code for specialty 30 providers. Claim has been forwarded to Palmetto. Clinic number missing or was not entered. Claim must be submitted to Railroad Board. Rendering physician number invalid, missing, and claim should be sent to United Mine Workers of America for processing. Here is the reasons we are rejecting bilateral screening mammography or mammograms. All the same as those I've mentioned, other than the clinic number was missing or not entered. 77063 is 3D mammography. You can see the reasons we are rejecting this, similar to those that we've talked about already, but one popping up here is that the facility is not certified for digital mammography. So that service would be rejected. The facility that performs the service must be certified by the FDA under the Mammography Quality Standards Act. And then the CPT code or the HCPCS code that's being billed must match that certification or match that facility's certification. CMS in their internet-only manual speaks about this certification of facilities for mammograms. It's in publication 100-04. That's the Medicare Claims Processing Manual, Chapter 8, Section 20, and that is a link to that is included in your in the resources listed at the back end of this presentation. Another reason this one is rejecting, rendering physician number invalid or missing. So, you know, when you look at these and realize the number of claim lines that we're rejecting for this specialty, these are really simple fixes. Pretty straightforward, these particular rejections that I'm talking about today. 70450 is the CT scan of the head or brain. Again, these are being rejected because they're being submitted to the wrong contractor. A couple of reasons, you know, 2 of the 5 most common reasons that this code is rejecting is because the claims are being sent to WPS when they shouldn't be. Clinic number missing or not entered, rendering physician invalid, missing. Next one, patient insured, and there's one of those acronyms, folks, that prints out on the remittance advice, and name do not match. And what's happening here with this particular one is that the name reported on the claim does not match the patient or insured's number, Medicare beneficiary identifier. It has to match exactly. If on the patient's Medicare card there is a middle initial used, then that middle initial needs to appear on the claim. 71046 is 2 views chest x-ray. Again, very, very similar reasons. If you look at just these 5 codes that I've shared with you so far, the most common reasons for claim rejections, these are things that can easily be fixed and resubmitted, of course, but we really want to bring your attention to the fact that this is what's happening with these claims, the most common reasons, so that we can avoid this altogether. If you put a dollar amount on each one of these claims that are being submitted, think of the money it costs you to prepare and submit that claim. Think of the money it costs Medicare to process that claim. That's a lot of unnecessary monies being spent. So we want to avoid these altogether. I mentioned to you that we can look at trending also. For this particular one, I looked at invalid or missing modifier. For that 3-month period or snapshot of data that I looked at, there was 407 rejections for this reason, invalid or missing modifier. The current for the current 3-month period, but the prior 3 months it was 384. There's a 23 claim increase, 6% change. I mentioned to you earlier that we use this data in order to know where we need to focus our education. All right, we've talked about rejections. Now it's time to talk about denials. The most common based on the data. That's what this webinar today is all about. During this webinar today, we're not talking about any claim-specific rejections and denials that you have, but rather those that are most common. Collection of fee-for-service during periods of managed care. I mentioned to you earlier that we get a lot of comments that mention that these codes, or these reasons rather, are a little cryptic. This one I actually had to follow up with someone in our systems department and ask them, does this really mean what I think it means? And it did. What this means is that these claims, 6,555, were denied because that patient was enrolled in a Medicare Part C plan, a Medicare Advantage plan. So we denied the service because it is not a traditional or original Medicare beneficiary. Next one, provider not eligible or certified for this procedure for this service date. I talked to you a little bit earlier about those screening mammography centers and the certification that's required. That could be one of these reasons. Or the provider may not be eligible on the date of service, but this one is actually specific to the procedure that's being billed, so this would indeed be those screening mammograms. Expenses incurred prior to coverage, 3,876 denials. Duplicate charge, and this is only one of many different types of duplicate claims that we have. We have duplicate charges. We have duplicate of a claim currently being processed. We have duplicate denials for a claim that was already paid on such and such a date under internal control number or ICN, and you know, it actually prints out for you on the remittance advice if it is it will actually show you the other claim ICN if there's a dupe for that reason. Duplicate claims have long been problematic. We have done a lot of education about duplicate claims and about a lot of these other reasons. Our YouTube channel has a lot of videos out there that speak to many of these topics I'm talking about today. But duplicate specifically, we've held webinars specifically about duplicate charges and ways to avoid those types of denials. We'll talk about that more in just a little bit, but I do want to call your attention to this because we really need to work on avoiding those duplicate charges or duplicate claims that are being submitted. Another common denial reason for your specialty is not covered when performed or referred or ordered by this provider. Providers not eligible to perform, render, or refer that particular item or service. Over 2,800 claims there. Here then are your common rejections by CPT code. Remember, this particular webinar today was designed to provide for you those most common rejections and denials and ways we can fix or avoid them. So it's important that we take a look at these codes. And then, if you're billing these at your facility, you can, pull some charts, see if you're submitting claims correctly, or pull some billings, I should say. Take a look at these specific codes. If these are codes that you are also submitting to Medicare, to make sure that you're avoiding these rejections and denials. 71045 is that single view chest x-ray. That was also the most commonly rejected code for your specialty, and the reasons we're rejecting or denying 71045 appear here. Over 13,000 claims. Expenses incurred prior to coverage, the provider's not eligible or certified for this procedure for this service date, and collection of fee-for-service during periods of managed care. And of course that would mean that that beneficiary had elected Medicare Part C. 70450 is the CT scan head or brain. Payment is included in another service received on the same day. That is a bundling type denial. So you can't bill this code separately from another service billed on the same day. Check to see what that other service was. Was it reported correctly? Was there a keying error? So on and so forth. There's that fee for service during periods of managed care. And here's another one popping up. These services are denied because the patient is in a hospice. I noticed that during the registration, some of you submitted a question that you wanted answered during this webinar today. Keeping in mind, of course, that some of you asked questions about topics that we're not covering today, but you can certainly submit those questions to customer service and someone will help you with those. If you have a claim-specific question, that will need to go to customer service too. But some of you asked about learning how to avoid denials for hospice. And of course, what you're going to have to do here is determine the eligibility of that patient. Has that patient elected hospice? Is that service related to the patient's terminal illness? So on and so forth. And we do have a resource available on our website. I'm going to show it to you here. Pull this open. What I've done here is pulled open a window that has our website here, the WPS website, wpsgha.com. And because there were multiple requests for this, I do want to mention or show you where you can find that information. Just choosing a Part B contract here. Right here, all I did, folks, was go out to the WPS website. I put the word hospice in the search box, clicked search, and here are 4 results for hospice. This very first one, billing services during a hospice election, is what you need to refer to in order to avoid these denials. This talks about the patient electing hospice benefits, that the services that are related to that would be processed for that beneficiary. This talks about the use of a modifier to tell Medicare that this service does not relate to the hospice condition. Okay, and of course your documentation would need to support the use of that modifier, GW. So there's the GV modifier, there's information here. You can submit the attending physician's professional services with this modifier when they're not employed by the hospice. And we will know that it is the attending physician's claim when it has that modifier GV. Here's some other information of how to submit claims correctly to Medicare when that beneficiary has elected hospice. Okay, so a great resource we have. I don't believe that that is on the list of resources. Maybe I did include it since it was one of the most common rejections. Or denials rather, not rejections. I caught myself there, folks. Rejections are different from denials. There's different actions you take to fix or correct rejections and denials. So there. The information here in this bullet is that services are being denied. This code 70450, patient in a hospice. All right, let's move on here. 71045 or 71046, I apologize, is chest tube views. Again, very, very similar reasons that these claims are denying. 74177 is the CT of the abdomen and pelvis. This is denying because this physician or supplier is not eligible to receive payment. When you see something like that, you need to check on the physician or the supplier's eligibility. You know, did you key it correctly? The identifier is on the claim. You know, you can contact provider enrollment to see, is there a termination date on that file, or maybe you're billing before that physician was eligible to receive payment. Either way, that would be a provider enrollment issue you want to look at. And again, here in expenses incurred prior to coverage, that one speaks to itself. Collection for fee for service during managed care. All very, very similar reasons. 77067 is bilateral screening mammogram. And this one's popping up due to frequency. Less than 1 year since the last screening mammogram. Of course, you need to check eligibility or use the SecureNet Access portal to check the date of that last mammogram in order to avoid this kind of denial. Eligibility is an issue here too because the patient's got managed care, Medicare Advantage plan, and the provider's not eligible or certified for this procedure for this service date. We talked about that earlier with the certification and such for radiology procedures. Here is the trending example, specialty 30 denials. And this one I chose, it was a little bit different, but it popped out at me because look at that last sub-bullet there, 255% change increase in the number of denials for this reason during that 3-month period. 369 during the current 3 months. There was only 104 denials the prior 3 months for charges incurred during an incarcerated period. 265 claim increase, 255%. The resource that I've included in your handout materials is, I didn't spell it right. And yes, I did. I thought I would look up the resource here, but I probably used a CMS resource. So there's nothing on our website, in which case I would look to the CMS website. I'm just doing a search, incarcerated. My fingers are going where I want them to. See if I can find information for incarcerated beneficiaries. And sure enough, there you go, folks. This is how I look for all of those great resources that WPS and CMS have. I do searches. I'm a searcher, not a navigator. And here then is where you can find the great resources that CMS makes available to help educate providers how to correctly prepare and submit claims to Medicare. So they want me to do the. So here's a lot of great information on this web page. Incarcerated Medicare beneficiaries, some questions and answers, explanation of what CMS considers as incarcerated, and so on and so forth. Talks a little bit about how the Social Security benefits work when someone is incarcerated, and talks about Medicare. So some great information out there to avoid those denials. So here then are the fixes. I know I talked about some of these as I went through. The fixes for those most common rejections and denials. Modifier issues. Make certain that you're reporting a modifier if one's required. Make sure that the modifier is one that can be used with that particular CPT code. You can call customer service and ask them, does your system accept modifier GW with CPT code, 12345? What you can't do is call customer service and give them a scenario. Patient came into our office. We did this, we did that. Can I use a modifier, XZ with CPT code 12345? I'm just pulling those out of the air, folks. You would need to keep it you know, very generic. Does your system accept this modifier with this procedure code? They can answer that. But don't give them a scenario and ask them if you can bill that way, because that would be considered coding, and contractors like WPS, the MACs, are prohibited from offering coding advice. We also have on our website, and this is included in the many, many resources, um, if you look on the WPS website, I'm going to navigate to this so you can find this later versus searching. You can simply search for modifiers, but you can also go to our topic center, choose claims, just choosing one of our Part B contracts, because today's webinar focuses on the top or the most common rejections denials for Part B claims. So I looked under claims, and right here is modifier and modifiers, and this, folks, is where you can find all of our really, what I think are great, very helpful fact sheets. Modifiers that kind of categorize bilateral modifiers, cardiovascular modifiers. This will help you uh, realize or submit or append modifiers correctly. And one of the things I do want to point out, and again, this is based on those the registration comments that were made. There was requests for education today, and we didn't advertise we were talking about this, so I'm not going to talk about modifiers 76 and 77, but it appears that someone, one of you that registered for this webinar today, or more than one of you, asked for some education on these modifiers, and the education we have available is here. The modifier 76 fact sheet includes the definition, repeat procedures by the same physician. So this is problematic sometimes for diagnostic radiology billers. So these fact sheets will help you report those repeat procedures performed on the same day. We've included appropriate use. We've included inappropriate use, and then some additional information that will help you submit those claims correctly. And what's happening here, of course, would be those situations when they are not reported correctly, or this modifier is not used correctly, and then this results in duplicate denials. And we want to help you avoid those duplicate denials when the services are indeed separate services that should be billed and considered for reimbursement. So this provides you with examples of how to bill also, or what not to do. So that would be the 76 fact sheet. Here, I'm going to pull open, scrolling down. Sorry about the movement here. The 76 fact sheet also, someone had asked about. And here's the appropriate use, inappropriate use, CMS reference, so it's a link to the internet-only manual publication. And this actually provides for you some examples that are taken from that internet-only manual of CMS's, some of which are radiology claims you can see here. Okay, so examples there right from the IOM. Helpful information to help you avoid denials and use these modifiers appropriately to avoid those denials. Eligibility, we talked about already. Remember that the patient name and the MBI have to match exactly. Make certain that you're submitting services to the correct payer. If it is a retired coal worker, that claim has to go to the United Mine Workers of America. If it's a Part C beneficiary, send it to the Medicare Advantage plan. Railroad Retirement Board is for those railroad retirees. CMS on their website has a map that you can click on any state, and it tells you where to send claims for beneficiaries in that state. So it will identify the various contractors. That's included in the resources at the end of the presentation. Provider number fixes. Make certain you're entering it correctly. We had some rejected claims earlier. Common reasons for rejected is that, the provider number wasn't, the provider identifier was invalid or missing. Make certain you're putting it on the claim. It's required. It's a required element. On the I'm talking about required elements here. I want to go back to the WPS website, and what I've done is gone to the home page, because the easiest way to get to our crosswalk is go to the home page, look under quick links, and choose EDI, Electronic Data Interchange. Scroll down when you go to EDI's webpage and choose Medicare. This is where you can find links to those companion guides that I talked about at the beginning of my presentation today, the 276, 277 companion guide. But what I want to show you now is this crosswalk. This crosswalk that I'm going to show you crosswalks a paper claim form to the electronic format, the 5010 version. So it's a table here that provides for you each item of the paper claim, the narrative, what it is that goes there, and then where do you need to put it on an electronic claim here. The version 5010, here's the loop, the data element descriptions there, requirements for the electronic claim is there in that last column. What I want to point out to you here is the status code column, and I'm just scrolling through trying to find some good examples here. You'll notice that some of the statuses are S and some are R, and you may ask, well, what does that mean? R means that that data element is required in order to process the claim. If it's not there, it's going to be rejected. S means situational, any data element that must be completed if other conditions exist. Now, sometimes these are denied versus rejected. It depends on what it is that is being asked for on that claim. So just something to keep in mind, but this is a handy tool that I like to share. This is the crosswalk. You'll hear us call it the crosswalk. Crosswalk's paper claim form to the 5010. Verify ordering provider information, rendering provider information. One of your resources is a list on the CMS website that tells you all the eligible ordering and referring providers in the US and provides their identification. Duplicate denials. I talked about this earlier. If you use a billing service or if you auto resubmit prior to establishing status for that particular item or service, stop doing that. It is considered abusive. You should not submit every 30 days, no matter what, or use a billing service that does the same thing. You need to check the status for that claim before just automatically resubmitting. Abuse can become fraud, so if you're contacted and educated that you're submitting claims for duplicate services, or you know that you're doing that and you continue to do that, it could be considered fraudulent at some point. We don't make those determinations, someone else does, but it costs everyone money. So you can save a load of money. A lot of the denials that we had, not just those that I talked about today that were specific to the data, but across the board, any specialty, duplicate denials continue to be problematic. Make certain you're billing them appropriately, identifying the correct modifier when using them. MSP denials are those situations when patient has other insurance that's primary to Medicare. If you look at that crosswalk, you will see that there are a lot of items on a claim that need to be reported that are situational as they pertain to Medicare Secondary Payer. So make sure that you're submitting all of the required information or that situational information on the claim when a patient has insurance that's primary to Medicare. Here are a lot of great resources for you. A fact sheet prepared by CMS. Our YouTube channel has playlists. One of the playlists is Rejections and Denials. Another playlist is the MSP playlist. Some of our staff in outreach have recorded a number of webinars already on these topics, so you can go out to that playlist and choose from it for some great information about MSP. I believe we had a situation today for bundling. Based on the data, of course, for the claims for your specialty, where claims are certain services are being denied because they're being bundled. Here is one of the resources for bundled claims. That would be the procedure-to-procedure code edits for the National Correct Coding Initiative. CMS has a contractor that maintains these edits for them. We have the procedure-to-procedure edit would be those bundling edits and other types of edits as well that didn't hit the data for you, but I've included them as great resources here. This last bullet is how to use the Medicare NCCI tools. Tells you how to look up these edits and such. So good information. Here's the information that I told you I included about those mammogram screening centers certification denials. It is in the IOM publication 100-08 that speaks specifically to reporting that certification number on the claim. If it's missing, your claim could be rejected or denied. If your certificate has expired or if there's changes in the certification, maybe the CPT codes that you're able to report is changing based on that certification, you need to contact provider enrollment so they can make those updates to your file. Here is the incarcerated beneficiary webpage. I told you earlier that I've linked to it here in your the resources portion of your handout or the prepared materials. Incarcerated individuals don't receive Medicare coverage, so Medicare denies those services. And this links to that webpage I showed you earlier. More resources and tools. We do have on our website a resource. Oh, let me back up a bit before I get to our website. Tell you that CMS's website has the internet-only manuals. We have both the paper claim format, what you need to put on the paper claim. Remember, if you leave off something that's required, it could be rejected or denied, one or the other. Here's that link to that crosswalk I showed you. So we have, the paper claim form instructions in the IOM and that crosswalk to avoid rejections and denials. You can use the IVR, the interactive voice response, to find claim status and details. 24 hours a day, 7 days a week. Of course, there is some limited functionality outside of normal business hours. This is that self-service tool. You use your voice or the telephone keypad, and we have the IVR operating guide available, linked in your handout and also on our website. Similar to that, and even I think a better tool is the SecureNet Access Portal. And I say better because you can get more information from it. You can, registered users can log in, check eligibility. Is that a railroad retirement or retired coal worker? You can check claim status, claim details. For WPS process claims, there is a button when you're looking at claim details. It says more info on that button. When you click that button, it will give you more details about that claim line that denied. If your service is denying because of a policy, it doesn't meet medical necessity, Medicare can't pay for this condition, it will link you to that policy if you're using SNAP. This is also available 24 hours a day, 7 days a week, with limited functionality outside of normal business hours. Instructions are available in the portal user manual. I do want to show you just how easy we make that. I'm coming over here with our website. I'm going to the home page by clicking on the logo at the top of the page, or you can click there on any page. Our portal user manual is available right here on our home page. There's a link to it. This is where you can register to become a SecureNet Access Portal, a SNAP user. Once you are a SNAP user, this is where you would log in. But here's that link to the portal user manual. Illustrations, step-by-step instructions on how to use the functionalities. I talked about that clerical error reopening a little bit earlier. So this would give you directions on how to use that self-service function, so on and so forth. Not only do we have a link to the portal user manual there, it's also available in this blue box that's located on the bottom of every web page. Right here, you just click on portal user manual to get to the manual. We have a resource specific to rejections, how to correct a rejected claim. I want to show you that real quick and zoom through a lot of these resources. I'm just going to key rejected claim. You can see what pops up here is how to correct a rejected claim. I want to show you this because this resource, what we've done here is we've listed those reason or remark codes. So if you get a remittance advice with the remark code M77, come right on out here, tells you how to fix it. Okay, so how to fix those rejections. That's for rejected claims. Similarly, we have a resource that speaks to common claim denials. Again, we list reason codes, remark codes. When we categorize these by the kind of denial there. Is it a bundling denial, a global surgery rule denial, entitlement denial, provider number denial? So again, go to these categories, look for those reason and remark codes. Tells you how to fix your claim or appeal it. Website, there's a code lookup tool on the home page. I don't know if you are aware of the availability of that tool. Real quick, I'm going to show you that tool. I can get my screen to open up here. Well, it's not wanting to. Having a little problem getting the page open. Let me just tell you then that there is a lookup tool. It is on our homepage, top left side of the homepage. You can key a keyword, a CPT code, or other type of code to see if there is a local coverage determination or a national coverage determination that has that in the title or within the document itself, because you can also search, in addition to the LCDs and the NCDs, you can search the LCD articles, that is local coverage determination articles. Here is links to our live events webpage, upcoming education, recordings that are available on our Encore presentations webpage. The recording of this webinar, a lot of information today, will be available out there probably sometime next week. Our YouTube channel has all those great videos you can watch, including Medicare Advantage plans and more. CMS resources for checking eligibility here. Here's that contractor directory I talked about. Interactive map where you can choose a state and find out, where do I send this claim, or a claim for a railroad retirement beneficiary? Where do I send that? And so on and so forth, or other types of contractors as well. This is where I would typically ask for questions and answers related to what I have covered today, what I advertised I was going to talk about. Unfortunately, we're at 10:59, so I do not have time for live questions and answers. If you have a question that pertains to what I've covered today, I'll be happy to answer that, and I'll share with you in just a minute how you can send those to me. Some of you might have already put a question in the chat. If it's a claim specific question, I'll not be able to answer it. But if it pertains to what I've talked about today, I will be able to answer it following this event. Now, some of you might be looking for continuing education units. In a few minutes, you will receive an automated email from WebEx. It's going to thank you for attending. If you're seeking continuing education units, don't delete it without reading it. It is in that email that you will find your certificate of achievement. It's going to look like what you see here on the screen with those red boxes. It's going to have your name on it, the contact hours, today's date, of course, and you'll be able to take that certificate of achievement in that email, take the email, and submit it to your accrediting body to ask them to award you with continuing education units. Now, if you don't see it, check your spam or your junk folder. If you find it there, you can add the WebEx email address to your safe sender list so it won't go to junk if you attend one of our future webinars. Now, if you join by phone today, you will not receive that automated email from WebEx. But if you need a certificate of achievement, send an email to our education mailbox. It's at the bottom of this slide. It's also on the next slide. Put today's date, the name of the webinar, and the telephone number you called in under, and we'll verify your participation and send you a certificate of achievement if you need it for CEU purposes. Now, here is the information on sending those follow-up questions. If you think of any presentation-related questions, or if you submitted one in the chat that I haven't answered because time ran out, you do have 1 week from today to submit them. Send them to our education mailbox and put Common Part B, Diagnostic Radiology Rejections and Denials. You can certainly abbreviate that if you'd like in the subject line, and the staff that's manning that mailbox will send that over to me so that I could get the response back out. Now, it's going to take a few days for me to wait for all of the questions to come in and answer those questions in an email. It won't be, if you send me the question today, you can expect it's not going to get responded to until I get all of these questions in. I'll send them to everyone who participated in today's webinar. Please take a few minutes to complete our brief survey. I know Tom has been putting some information in the chat feature about this survey. This survey is so very important to us. Your feedback really is invaluable in ensuring education that is timely and effective. There's different options depending on your preference, of course, but this survey is so important. We're going to give you even another chance to complete it if you haven't done so already. When you exit the webinar, you're going to be redirected to the CMS Qualtrics page for the survey. It's going to look like that box at the bottom of the page with the yellow triangle on the top. If you've not already created the survey, please use that opportunity to do so, or the link that is included in your presentation materials. On behalf of myself and Tom and all of Provider Outreach and Education, we do want to thank you for your participation. We look forward to those survey comments, and we hope to have you join us for future events. You may now disconnect. Thanks, everyone. Have a great day.